chapter with this last PowerPoint, and that will include how we make adjustments to respiratory rates depending on several factors, some respiratory diseases, and the developmental aspects. So let's look at respiratory adjustments first. When we are exercising, adjustments have to be geared to deal with the intensity and the duration. Hypernia is an increased ventilation in response to metabolic needs, and that can increase ventilation 10, 20 fold. Ventilation will increase abruptly, can increase gradually, and then reach a steady state. When the exercise stops, there's a small, abrupt decline in ventilation followed by a gradual decrease. And the levels of CO2, oxygen, and pH, because of these things, remain surprisingly constant during the course of exercising. Abrupt increase in ventilation that occurs as exercise begins involves neural factors, the psychological stimuli, simultaneous cortical and motor activity of skeletal muscle and respiratory centers, excitation impulses to the respiratory center from proprioceptors and moving muscles, tendons, and joints, and the gradual increase and plateau of respiration reflects that it's caused by an increased rate of CO2 delivery to the lungs. Ventilation declines suddenly as exercise ends because of neural factors. They're being shut off, and it gradually goes back to baseline due to the decline in CO2 flow after exercise ends. This exercise is going to lead to anaerobic respiration and the formation of lactic acid, and this respiration is metabolic when we're making ATP, so this is glycolysis. The lack of oxygen in the muscles is not from poor respiratory function, rather insufficient cardiac output or skeletal muscles' inability to increase oxygen uptake. You're moving to high altitudes, above 2,400 meters, which is roughly 8,000 feet. That can trigger symptoms of acute mountain sickness, which is due to the fact that the atmospheric pressure and partial pressures of oxygen levels are lower at high elevations. Some of the symptoms would include headache, shortness of breath, nausea, and dizziness. And in severe cases, you can get a lethal cerebral and pulmonary edema occurring, a swelling within the brain and lungs. Acclimatization is when the respiratory and hematopoietic adjustments are made with long-term moves to high altitude. When you get acclimated to those altitudes, chemoreceptors become more responsive to CO2 when oxygen declines. A substantial decline in oxygen would directly stimulate peripheral chemoreceptors, and that results in an increase in minute ventilation that stabilizes in a few days to 2 to 3 liters higher than you would have been at sea level. High altitude conditions always result in lower than normal hemoglobin saturation levels due to less availability of oxygen, and decline in blood O2 stimulates kidneys to accelerate the production of EPO, the hormone that helps make red blood cells, which will increase the number of red blood cells slowly, and that provides for a long-term compensation to lower levels of oxygen. So, lung diseases. Chronic obstructive pulmonary disease, COPD, exemplified by emphysema and chronic bronchitis. The feature of this is the irreversible decrease in the ability to force air out of the lungs. Other common features, most people with COPD, at least 80% of patients, have a history of smoking. They suffer from dyspnea or labored breathing. They are air hungry. They cough and have frequent pulmonary infections, and most patients develop hypoventilation accompanied by respiratory acidosis and hypoxemia. Emphysema is the permanent enlargement of the alveoli and destruction of the alveolar walls, which results in decreased lung elasticity, and that has 3 key consequences. The accessory muscles are going to be necessary for breathing. That leads to exhaustion. You use 10 to 15% more energy to breathe than normal. Trapped air can cause hyperinflation, and that will flatten the diaphragm and cause the expanded barrel chest that is typical of these patients. And damaged pulmonary capillaries lead to enlargement of the right ventricle of the heart. One of the hereditary factors we know for this disease is an alpha-1 antitrypsin deficiency. Chronic bronchitis can be from inhaled irritants that cause chronic excessive mucus. The mucus of the lower respiratory passageways becomes inflamed and fibrosed, and that results in obstructed airways that impair lung ventilation and gas exchange. Symptoms would include frequent pulmonary infections. Their risk factors here would again include smoking and other environmental pollutants. COPD symptoms and treatments. Strength of the patient's innate respiratory drive is a reason behind the different symptoms that are seen. Some patients are referred to as pink puffers because they usually thin, burn large amounts of energy breathing, and have near normal blood gases, so skin color is normal. The other groups are blue bloaters, in which the patient's usually stocky, suffering from cyanosis, and skin color takes on a bluish hue. For both, the treatment is bronchodilators, corticosteroids, oxygen, and sometimes lung volume reduction surgery. And oxygen must be administered carefully to these patients. So here's pathogenesis of COPD, and I recommend you look this over in your textbook. Asthma, sometimes classified as chronic obstructive pulmonary disease, but the episodes are generally acute and not chronic, and there are long symptom-free periods. Asthma is characterized by coughing, dyspnea, wheezing, and chest tightness. There's an active inflammation going on in the airways that precedes these bronchospasms. That airway inflammation is an immune response caused by the release of interleukins, production of IgE antibodies, and the recruitment of inflammatory cells. The airways become thickened with inflammatory exudate, and that magnifies the effects of the bronchospasms. Tuberculosis is a disease caused by a microbacteria, a Mycobacterium tuberculosis. Patients would have fevers, night sweats, weight loss, racking cough, and even coughing up blood. Tuberculosis lives inside of cells within your body. So it's an intracellular bacteria. It's difficult to get antibiotics into the Mycobacterium to treat them, so it requires a long course of antibiotics, a 12-month course, year-long course of antibiotics. And that has worked for a very long time, but we are increasingly seeing multi-drug resistant strains of tuberculosis as a result of people not completing their 12-month course of antibiotics. Lung cancer is the leading cause of cancer deaths in North America. Almost 90% of the cases are the result of smoking, but keep in mind that leaves 10% of the cases there's no history of smoking. So think about that when you hear someone has lung cancer. It may or may not be their fault. Three most common types are adenocarcinoma, which is about 40% of the cases, starts in peripheral lung areas and develops from bronchial glands and alveolar cells. Squamous cell carcinoma is about 20% of the cases. It arises from cells in the bronchial epithelium. And small cell carcinoma, about 15% of the cases, have lymphocyte-like cells that originate in the primary bronchi and then very quickly metastasize. Early detection is the key to lung cancer survival, but unfortunately the symptoms don't show up till late. If metastases haven't occurred, surgery to remove the diseased lung. If metastases have occurred, radiation and chemotherapy, and there are lots of new therapies on the horizon, but the best way to avoid lung cancer is to avoid smoking. Sleep apnea is a common disorder characterized by temporary stopping breathing when you sleep. Person usually isn't aware of the problem, but it leads to excessive daytime sleepiness, waking up several times in the night. Some people wake up as many as 30 times per hour. Obstructive sleep apnea is the most common type, and it's caused by a collapse of the upper airway. Pharynx muscles are relaxing when we sleep, and they sag to cause the obstruction. Central sleep apnea is caused by a reduced drive from the respiratory centers in the brainstem. And the consequences of disrupted sleep include susceptibility to accidents, an increase in chronic illnesses such as hypertension, high blood pressure, heart disease, stroke, and diabetes. Obstructive sleep apnea can be treated using CPAP, which is a continuous positive airway pressure device, and that pressure keeps the airway open, keeps the airway patent, preventing it from collapsing. Developmentally, the upper respiratory structures develop first. We get olfactory placodes that invaginate into olfactory pits. The laryngotracheal bud is present by week 5. By 28 weeks, premature babies can breathe on their own. During fetal life, our lungs are filled with fluid because we're not picking up air, oxygen from our lungs, and blood will bypass the lungs. Gas exchange will take place through the placenta. At birth, the respiratory centers are active, the alveoli inflate, and the lungs begin to function. It takes about 2 weeks before the lungs are fully inflated. Respiratory rates are highest in newborns. They can be up to 40 to 80 breaths per minute, and they will slow to adulthood, where we get to between 12 and 16 breaths per minute. The lungs continue to mature, more alveoli are formed until young adulthood, and respiratory efficiency will decrease with old age. Cystic fibrosis is the most common lethal genetic disease in North America. Its abnormal viscous mucus is going to clog passageways of the respiratory system, lead to bacterial infections, but it also has an effect in the pancreatic ducts and the reproductive glands as well. It's not just a lung disease. It's caused by an abnormal gene for a chlorine membrane transport protein, the cystic fibrosis transmembrane conductance regulator, CFTR. So an abnormal CFTR gets stuck in the endoplasmic reticulum and never makes it to the cell membrane, so it cannot transport chlorine the way it is supposed to. Treatment for cystic fibrosis involves mucus-dissolving drugs to manipulate and loosen the mucus, also antibiotics to prevent infections, inhalation of hypertonic saline to thin the mucus, and there is a tremendous amount of ongoing research trying to introduce a normal CFTR gene into respiratory tract mucosal cells, prodding different proteins to take that over, and looking at ways to get the CFTR from the endoplasmic reticulum to the cell surface where it should be.